Spilled saline on a hospital floor looks like nothing. That is the first thing I want you to know. It is clear. It catches the light differently from water only if you are looking for it, and nobody on the overnight ICU at Clair Medical Center in Cincinnati, Ohio is ever looking at the floor when there is a patient crashing somewhere above it. You register it only in the peripheral way you register everything that is not the immediate emergency, as a condition of the environment, a feature of the floor, something the housekeeping team will manage before the morning shift arrives. But saline on a floor leaves a residue. When it dries, it leaves the specific faint crystalline trace that salt leaves on any surface it evaporates from. And that residue, in the right light, captures footprints. Not footprints pressed into the residue the way footprints press into snow or sand. More subtle than that. The specific interruption of an even surface by the weight of a passing body. The way a shoe sole disturbs the crystalline layer in a pattern that, if you look closely, tells you exactly how many people have walked across this floor, in what direction, and approximately when. Every person who has walked across that floor in the overnight hours has left a record in the dried saline. Every person except one. Her name was Vera Strand. At least, that was the name on her badge. That was the name Cole Whitman, which is me, which is the physician telling you this story, called her for 3 years of overnight shifts in the ICU at St. Clair. That was the name we all used. And in the specific way that you do not investigate the names of people who are making your floor run well at 2 in the morning, we used it without examining what was behind it. We should have examined it. The examination, when it finally arrived, did not come from us. It came from a man in a plate carrier at the end of a very bad night who looked at the woman I had trusted for 3 years and said a different name, a classified name, the name that explained the saline. I have been an overnight ICU, attending at St. Clair Medical in Cincinnati for 7 years. Cincinnati is a river city. It sits on the north bank of the Ohio, and it has been a working city, a manufacturing city, a port city, a city with the specific character of places that have been doing hard things for a long time and that have developed, over generations of doing hard things, a certain directness about it. The people here do not perform their competence. They simply demonstrate it. The overnight ICU at St. Clair has always had that quality. We are a 22-bed unit on the 4th floor of the East Wing. We are not a trauma center. St. Clair does not receive the penetrating wounds and the high-speed MVAs that a level 1 facility sees. We receive the critically ill, the post-operative complex cases, the septic patients, the cardiac patients in the specific post-event period when the acute intervention has been completed and the sustained management begins. We receive patients who have been through the worst, and who are now in the specific uncertain territory between having survived the worst and being permanently on the other side of it. The overnight ICU is where those patients spend their most vulnerable hours. I chose nights because of this. Vera chose nights for the same reason. She told me this the first week she was on the floor. In the specific direct way she said everything. The nights are when it matters most. Days have coverage. Nights have us. She said it the way a person states a fact that everyone in the room already knows, and that someone has simply decided to say out loud. I trusted her from that first week. I trust quickly when the evidence warrants it. 3 years of evidence warranted it. And then came the night of August 15th. Before we go any further, if this is the kind of story you want more of, hit subscribe, drop a like, and tell me in the comments what city you're listening from tonight. I read every single one. She arrived the way good nurses arrive in hospitals that need them, without announcement and already present. One night she was not on the floor. The next night she was. Standing at the medication prep counter with the practiced ease of someone who had been standing at that particular counter for years, despite the fact that, as far as any of us knew, she had never been in the building before. She knew where things were. Not in the way of someone who had read a floor plan or completed a competency check. in the way of someone who has navigated the specific geography of a working unit enough times that the geography has become automatic. The supply room that sticks on the left side. The medication cabinet that requires a firm push at the top before the drawer opens. The specific quirk of the monitor in bed 18 that runs the saturation reading a point low and needs to be compensated for. She knew all of it on the first night. I noticed this. I filed it under Rapid Learner, Impressive Start. I moved on, because the unit needed moving on and rapid learners were what I needed, and I did not ask how the learning had been so rapid. Her hands were cold. This was the first thing my charge nurse Karen mentioned. Karen had been on the overnight ICU for 11 years and had developed, over those 11 years, the specific authority of someone who knows more about a floor than anyone in administration will ever know, and who exercises that authority without needing to name it. She said, "Have you touched her hands?" And I said I had not, and Karen said, "Touch her hands." So I shook Vera's hand at the end of a shift and Karen was right. Cold, not the cold of a chilly room, the cold of a circulatory system that runs at a different register from the ordinary. I filed it. She was undeniably striking in the specific way of people who are not conventionally beautiful, but who carry something that makes a room orient toward them. Dark hair pulled back in the plain, functional way of someone who does not dress for work, but dresses for the work. Brown eyes that were, in the years I worked alongside her, the most focused eyes I had ever seen in a clinical environment. She was not tall. She moved with the economy of motion that you develop when you have been in environments where unnecessary movement is not a luxury the situation can afford. I noticed this. I did not ask. Karen came to me in the break room midway through Vera's 3rd month on the floor. She sat down across from me with the expression she used when she had something important to say and had been weighing whether to say it. She said, "The badge." I waited. She said, "She does not use her badge." I have been watching for 6 weeks. She waits for someone else to open the secure doors, and she slips through behind them. I have never once seen her swipe the reader. I said, "Maybe the badge has a fault." Karen looked at me with the expression of someone who has 11 years of overnight ICU authority and is not interested in easy explanations. She said, "I pulled the door access log for the past 6 weeks. Her badge number does not appear in it. Not once. Not in 6 weeks of shifts. I thought about this." I said, "Has she done anything wrong?" Karen considered this seriously. "No. Every intervention has been correct. Every assessment has been accurate. Every family conversation has been appropriate." A pause. "She is the best nurse I have had on this floor in 11 years. I said, "Then let's keep watching." Karen nodded. She stood up. At the door she turned back and said, "Also, she doesn't eat. 3 months, not once. And she doesn't sweat. Ever. You will think about that." She left. I thought about it. The thing about the saline came in month 5. A hanging IV bag on bed 7 had sprung a leak at the port connection. Not uncommon, equipment degrades, the specific failure of a component that has been used more times than its tolerance allows. The bag drained onto the floor before anyone caught it. A large puddle, which the housekeeping team wiped up, but which left the specific dried residue I described at the start of this story. The crystalline trace of evaporated saline on the linoleum. By the end of the next shift, that residue had been walked through by every person who had entered bed 7's bay. I walked through it. Karen walked through it. The resident walked through it. The transport staff walked through it. 2 family members walked through it. Every pass left the specific interrupted pattern of a shoe sole in the dry film. Vera had been in that bay for 40 minutes managing a medication titration. Her section of the floor was undisturbed, clean, as if she had not been there. I stood in the doorway of bed 7 and looked at the floor for a long time. Then I looked at the wall beside the door, where the camera was mounted. I pulled the footage that night. The footage showed Vera entering the bay, working at the bedside, adjusting the medication pump, checking the monitor, speaking to the patient. All of it clearly recorded. All of it unambiguous. The footage also showed her feet. Or rather, the footage showed the floor where her feet should have been. And the floor where her feet should have been was the same clean, undisturbed residue it had been before she entered. She had been in that bay for 40 minutes. The floor did not know it. I sat with this for a long time. Then I filed it. I filed it because I had a unit to run, and Karen was right, that she was the best nurse on the floor, and whatever the explanation was for the saline, the explanation was not producing harm, and producing harm was the threshold I was working with. I kept working. August 15th arrived. I want to tell you what 3 years of working alongside Vera Strand looked like from the inside. Not because the 3 years are the point, August 15th is the point, but because August 15th only makes sense if you understand the 3 years that preceded it. Vera was the nurse that every physician on the overnight team requested when the case was difficult, not out loud. Nobody on the overnight ICU makes formal requests for specific nurses on specific cases, because the overnight ICU does not work that way, and the administration does not accommodate it, and the staffing does not permit it. But informally, in the way that floors develop informal practices alongside their formal ones, every physician who worked the overnight ICU at St. Clair for any extended period knew that if Vera was on the floor and the case was complicated, you wanted her at the bedside. The knowledge she carried was not the knowledge of nursing school. I need to be precise about this because it is the center of the story. Nursing school produces nurses who are excellent. The curriculum is comprehensive and the certification process is rigorous, and the nurses who complete it carry a body of clinical knowledge that is both deep and broad. I am not dismissing nursing school. I am saying that what Vera knew had a different texture from what nursing school produces. The same way that a musician who has studied conservatory has a different knowledge from a musician who has played in war zones. Same fundamentals, same instrument, different depth of experience in the specific registers where the fundamentals are tested by reality. Vera's knowledge had been tested by reality. I knew this before I knew what reality it had been tested in. The way she assessed shock states, for instance. The standard nursing assessment of shock is systematic and correct and is derived from textbook understanding of the physiology. Vera's assessment was all of that and something additional, an almost tactile read of the patient's circulatory state that went beyond the measured parameters and into something that could only be called clinical intuition. Except that clinical intuition is a phrase that means the pattern matching of very deep experience rather than anything mystical, and the experience her intuition was pattern matching against was deeper than the experience of an ICU nurse in a Cincinnati hospital, or the way she managed airways under pressure, or the way she read a chest X-ray. ICU nurses read chest X-rays. They are trained to identify the relevant features, pneumothorax, effusion, tube position, infiltrate pattern, and to communicate those findings to the clinical team. Vera read chest X-rays the way a radiologist reads them. Not in terms of the final report, not in terms of formal interpretation, but in terms of the specific, layered reading of a film that has been developed by years of looking at films in environments where the film was the only imaging available, and where reading it correctly was not an academic exercise. She had been somewhere where chest X-rays were the only imaging. She had been somewhere where a mistake in reading them killed someone. I knew this before I knew where. The cases she saved that the unit still talks about. Mr. Okonkwo, 62, post-cardiac surgery, who developed a pericardial effusion on day 3 of his ICU stay that the team had classified as small and stable. Vera flagged it on a Tuesday and told me, in the flat, unhurried way she delivered all clinical information, the effusion is not stable. The echo from this morning underestimates the volume. The specific pattern of the neck veins and the pulsus paradoxus on the last 4 readings suggests early tamponade. If we wait for the next scheduled echo, we may be having a different conversation. She named the specific cardiac pressure measurements she expected to find. They found them. We called cardiology. The pericardiocentesis was performed. The effusion was twice the volume the echo had shown. Okonkwo went home 3 weeks later. His wife sends a Christmas card to the unit every year addressed to the entire overnight team. I have framed the last 3. Mrs. Vasquez, 48, liver failure, who presented with the specific coagulopathy of end-stage liver disease, and who had received the standard coagulopathy protocol, and whose bleeding was not responding to it at the rate the protocol predicted it should respond. Vera came to me and said, "The fibrinogen is the problem. The INR looks like the primary issue, and the FFP is addressing the INR. But the functional coagulopathy, in this specific presentation, is fibrinogen-driven. The cryo is what we need, and we need it now before the protocol catches up to what her body is actually doing." She was specific about the dose and the timing. We followed her recommendation. Vasquez stopped bleeding. She is on the transplant list now. The prognosis is cautiously good. There were others. A dozen others, over 3 years, where Vera knew something that the standard clinical framework had not yet caught up to, and where acting on what she knew made the difference between the case going the right way and the other way. I documented each one. I asked her, after each one, how she had known. She always gave me a clinical answer. A correct, precise, technically accurate clinical answer that explained the finding in terms of the physiology and the data. The answers were never wrong, they were simply not complete. The complete answer came with August 15th. Before I get to August 15th, I want to tell you about the small things. The large things, the saline, the badge, the cases she saved, are easy to describe because they are specific and documentable. The small things are harder to describe because they are made of texture and tone and the specific quality of a person's presence over an extended period of time, which is not the kind of thing that fits cleanly into a deposition or an incident report, but which is, for the people who experienced it, the most real thing about working alongside her. She did not perform comfort. This was the thing that the families of our patients noticed most, in the specific way that people who are exhausted and frightened notice things that they cannot name, but that they can feel. Most of the comfort that is provided in an ICU is correct and genuine, and is still, in some small way, performed, delivered through a practiced warmth, through the language of consolation that becomes habitual over years of providing it, through the specific professional modulation of empathy that is necessary to do this work without being consumed by it. The performance is not dishonest. It is the form that genuine care takes when it has to be delivered at scale. Vera's comfort was not performed. When she sat with a family, the quality of her presence was not the quality of someone doing a job well. It was the quality of someone who was simply and entirely with the person in front of them. Families noticed this. They could not always articulate what was different. But they noticed it, and they came back to it, and the families of the patients who did not make it wrote to the unit afterward about the nurse who had been with them, and the nurse they described was always Vera. She also knew things about the patients that she should not have known, not medically. Personally, the patient in bed 11, a retired fire captain named Gerald Marsh, who had been admitted with a stroke and who was speaking very little, and whose family was at a loss for how to reach him. Vera sat with him for 40 minutes one night, and when she left, he was speaking. Not much, but speaking. She had said, when his daughter asked what she had talked to him about, "I asked him about a fire, a specific one. He seemed to want to talk about it." His daughter looked at her and said, "That fire was 40 years ago. It was the fire that made him a fire captain." "How did you know to ask about it?" Vera said, "He has a small burn scar on his left forearm that is older than the others. The angle and the pattern of it suggest a rescue." People who have done a specific thing that changed their life tend to carry the physical evidence of it in a way you can read, if you know what to look for. Gerald Marsh spoke continuously for the next 3 days. He was discharged to rehab 6 weeks later. His daughter wrote a letter to the hospital that used the phrase she saw him when nobody else could. That phrase has stayed with me. And then there was the way she moved at night. The overnight ICU at St. Clair has a specific quality of sound in its deep hours. the monitors, the ventilators, the specific ambient frequency of a floor running at its minimal staffing level, a frequency that the staff who work overnight regularly develop a relationship with, a recognition of the floor's baseline sound that means when the baseline changes, the change registers before the consciousness has processed it. Vera moved through that soundscape without altering it. Every other person on the floor produced a specific contribution to the ambient frequency, the sound of shoes on linoleum, the soft impact of doors, the particular quality of a person's breathing in motion. These contributions were not loud. They were simply present, the way all physical movement through air and against surfaces is present. You could track the movement of any person on the floor at night by their contribution to the ambient frequency if you were paying attention. Vera contributed nothing. She moved through the night floor of the ICU without adding to the sound of it. The doors she passed through made no sound. Her shoes produced no sound. She was present in rooms and absent from rooms, and the transition between the two states produced no auditory evidence. I noticed this in month 7. I filed it. I kept working. The night of August 15th began as an unremarkable night. This is the specific deception of nights that are about to become remarkable. Their beginning is identical to the beginning of all the nights that were not remarkable. The ICU ran its standard overnight protocol. The patients were at their various positions on the continuum between critical and stable. The staff was the regular crew: Karen, Vera, 2 other nurses whose names are in the record, the overnight resident, and me. I was at the monitoring station doing my late evening chart review when the elevator opened, not the patient transport elevator, the staff elevator, the one that requires a key card for after-hours access. 4 men came out of it. They were in civilian clothes, dark jackets, dark pants, but the civilian clothes sat on them the way civilian clothes sit on operators, correctly and also wrong, the way a tailored suit sits on a man who is not used to wearing tailored suits. It fits and it does not fit simultaneously. The bodies underneath were not civilian bodies. They were bodies that had been through things, that carried the specific compact density of people who have been required by their profession to be as capable as possible at all times, and whose physical selves reflect this requirement. The man at the front held a federal credential as he walked toward me. I read enough of it before he reached the station. Naval Special Warfare Command. The relevant part was not the agency name. The relevant part was the look on his face. He was not aggressive. He was not performing authority. He was simply and completely serious in the way of someone for whom the current situation is the most important situation, and who needs the person in front of them to understand this without the understanding requiring extended explanation. He said, "My name is Chief Warrant Officer Ray Dunn. I have a critically injured operator. He has been in a compromised exfil. I need your best ICU physician and your best ICU nurse, and I need them in the same room as my man in the next 60 seconds. He said it without raising his voice. I said, "What is he presenting with?" He said, "Septic shock on top of a week-old penetrating abdominal wound that was managed in the field, and that has developed a complication we have not been able to address without a facility. His name is Petty Officer First Class Leon Hayes. He is 29 years old. He is the best operator in my unit, and he is running out of time." I said, "Bring him in." Leon Hayes was large in the way that certain operators are large, the functional large of a body that has been built by sustained physical demand over many years, rather than the aesthetic large of someone who has worked for size. He was carried in on a collapsible stretcher by 2 of the operators. His color was wrong, the specific gray-yellow of a septic patient whose inflammatory response has been running unchecked for longer than the body can sustain it. The wound was the center of the problem. A penetrating abdominal injury managed in the field a week ago that had been initially controlled, but that had, over the subsequent days, developed a complication that field medicine had not been able to resolve. The complication, when I read it in the first assessment, was a contained intra-abdominal abscess that had ruptured, not dramatically, not with the acute abdomen presentation of a full perforation, but with the specific slow leak of a contained collection that had breached its wall and was now seeding bacteria into the peritoneal cavity at a rate the antibiotics could not keep up with. He had been running a fever for 4 days. His blood pressure was low in the way of a patient whose vasculature has been under maximum endogenous vasopressor load for an extended period and is starting to exhaust the load. We had 2 problems. The first was the infection. The second was that the infected source, the ruptured abscess, was still present and actively contaminating, which meant the antibiotics could not arrest the sepsis, because the antibiotics could not sterilize a source that was continuing to seed. He needs interventional radiology, I told Dunn. The abscess needs to be drained. The antibiotics need to be tailored to the specific organism. We need cultures. And his hemodynamics need to be supported aggressively while we work on the source. Dunn said, "What is the timeline? If the source is not addressed?" I stopped. I said, "We need to move fast." Dunn looked at me. He said, "He has been in conditions that would have killed most people before he reached your hospital. He made a decision to stay operational past the point where most people would have evacuated. He made that decision because the mission required it, and because he is the kind of person who does not stop when stopping is available." He paused. "I need him to come out the other side of this," I said. "We are going to do everything we can." I meant it. I went to find Vera. She was at the monitoring station when I came out of Hayes's room, charting. The specific, methodical documentation that she brought to everything, each entry complete, each observation recorded with the precision of someone for whom accurate documentation was not bureaucratic compliance but professional obligation. She looked up. She had the expression she always had at the start of a serious case, not alarmed, not performing urgency, simply present, fully deployed in the direction of what was required. I told her the presenting picture. She listened without interrupting. This was something I had always noticed about her. She never interrupted a clinical briefing. She received the information in the sequence it was delivered and integrated it without requiring it to be repeated. When I finished, she said, "The organism," I said. "We won't have the cultures for hours." She was quiet for a moment. She said, "The mechanism of the original injury, the geography of the exfil. What do you know about where he has been?" I looked at Dunn, who had followed me out. Dunn said, "I cannot tell you where he has been." Vera looked at him. She said, "I understand that. I am asking about the organism, not the geography. The specific combination of his fever curve, the character of the drainage from the wound, and the timeline of the deterioration relative to the initial management tells me something about the likely organism. It tells me more if I know whether the water he was near was fresh or salt, whether the soil exposure was coastal or inland, and whether the ambient temperature in the operational environment was above or below 30 degrees Celsius. Dunn was very still. He said, "Coastal. Salt water. Ambient temperature above 30. Vera said, "Then the empirical coverage is incomplete. The standard gram-negative coverage does not address the specific marine organism that this presentation is consistent with. I have seen this before. The antibiotic you need is not what the standard septic abdomen protocol specifies," I said. "How do you know this?" She said, "I have seen it before. In a context I will explain to you later. Right now I need you to trust me. Change the antibiotic. Start the drainage. Run the hemodynamic support." In that sequence, I looked at Leon Hayes through the glass of his room. His blood pressure on the monitor was 72/40. I looked at Vera. 4 years of not being wrong. I said, "Change the antibiotic." "What do we use?" She told me. I used it. The interventional radiology team drained the abscess. The procedure was technically clean. The collection was well defined on imaging. The approach was straightforward. The drainage was complete. The material that came out of that collection was sent to the lab, and the lab would, in the hours that followed, confirm what Vera had told me about the organism. Not immediately. The confirmation came later, but it came. The antibiotic Vera had specified was the correct antibiotic for the confirmed organism. The hemodynamic support ran alongside the source control and the antibiotic optimization, and over the following hours, the slow, grinding, non-dramatic hours of a septic responding to correct management, Leon Hayes's blood pressure began to climb. Not fast, not dramatically. The specific, incremental climb of a body that has been given the correct intervention and is beginning to use it. His fever broke. His lactate began to clear. Karen came to me midway through the shift and said, with the restrained professionalism of a nurse who has seen patients come through bad situations many times and who does not declare victory prematurely, he is going in the right direction. Yes, she said. She knew the organism. Yes. Karen looked at me. She said, where did she know it from? I said, I am about to find out. He found me in the family consultation room, not because I had asked him there. Because he had been sitting in the corridor outside Leon Hayes's room for the full duration of the treatment, and had read the trajectory in the monitors through the glass and had understood, with the specific operational intelligence of someone who has spent a career reading situations at a distance, that the situation had changed, and that the changed situation required a conversation. He sat across from me. He said, it is working. Yes, I said. The antibiotic she recommended. Yes. He was quiet for a moment. He said, the organism she identified. I need to tell you something about that organism and about who knows it. I waited. He said, the specific organism that presents the way Leon Hayes presented, with that fever curve, in that wound, in that environment, is not in the standard infectious disease literature for a reason. It is in the classified operational medicine literature. It was identified and cataloged by a specific medical team working a specific operational geography over a specific period of years. The number of people who have personally managed a case presenting with that organism is not large. The number of people who have managed it well enough to be confident about the first-line antibiotic before the cultures confirm it is smaller. He looked at me. He said, what is your nurse's name? I said, Vera Strand. He said, I need you to describe her. I described her. The dark hair, the brown eyes, the cold hands, the specific economy of movement. Dunn closed his eyes for a moment. Then he opened them. He said, that description matches a person whose file I am familiar with. A person who was embedded with an interagency medical team operating in the specific operational geography I am describing. A person who spent 2 years developing the specific medical protocols for the specific pathogens associated with that geography. He said, that person was declared missing in action 14 months ago. He said, her name was not Vera Strand. The consultation room was very quiet. I said, what was her name? He said, a name. I will not put that name in this account because it is not mine to put there, and because the operational circumstances that surround it are not mine to describe. What I will tell you is what I did with it. I went to the administrative archive. The administrative archive at Clair Medical goes back to the hospital's founding. The deep historical employment records, the paper files from before the 2008 digitization, scanned and stored in a back-end folder that nobody accesses, because everything relevant is supposed to be in the current system, contain employment records going back decades. I searched the name Dunn had given me. It took 14 minutes. When the record loaded, it loaded as a scanned document. An old hospital badge photograph. A face I recognized. Brown eyes. Dark hair. The specific economy of expression of someone who does not perform anything. The badge format was old, the previous design, before the 2014 refresh, but the face was current. Beneath the photograph, the name, the role, the unit, St. Clair Medical Center, Overnight ICU, nursing staff, employment dates spanning 4 years. Starting date 12 years before she disappeared into the operational record. Ending date, the week she left for the program that led to the work that led to the 2-year gap that led to the name Vera Strand. She had worked here before. Not in the way of someone who had happened to work here as part of a career path. in the way of someone who had learned who she was as a nurse in these specific rooms, on this specific floor, with these specific patients, who had built the foundation of everything she subsequently became in the ICU at St. Clair. She had come back, not to hide, to use what she knew in the place where she had learned it. I sat at the archive terminal for a long time. Then I went to find her. Let's take a quick break. If this is the kind of story you want more of, don't forget to hit subscribe, drop a like, and tell me in the comments what city you're listening from tonight. Now back to it. She was in the supply room at the end of the east corridor. The supply room is a narrow space between the medication prep area and the equipment storage, a utilitarian room, metal shelving, inventory, the specific functional clutter of a unit that has more equipment than storage space and that has learned to organize the excess with the pragmatic geometry of people who need to find things quickly in the dark. It is not a place where staff spend extended time. You go in, you get what you need, you go out. Vera was standing in it with her back against the shelving, her eyes closed, her hands flat on the metal surface behind her. The specific posture of someone who is using the physical contact with a solid surface to manage something that would otherwise be unmanageable. I recognized it, though I had not had a name for it before. The deliberate grounding of a nervous system that has been through something significant and is integrating it through sensation rather than thought. She opened her eyes when she heard me in the doorway. She looked at me with the brown eyes that I had been reading for 4 years and that I understood now I had only been reading the surface of. She said, "Ray Dunn is in the building." Yes, said. He identified me, from the description. Yes. She was quiet for a moment. Her hands were still flat on the shelving behind her. She said, "Leon Hayes is going in the right direction." Yes, I said. He is going in the right direction. She closed her eyes briefly. The specific involuntary moment of someone receiving confirmation they needed. She said, "I will tell you everything. I owe you that. But I need a moment first." I leaned against the opposite shelving and waited. She took the moment. Then she opened her eyes. She said, "The badge. The saline. The things that did not add up." Yes, I said. "How long have you known?" "Known?" "Never. Noticed. Since month 5. She nodded slowly. "And you kept working with me. You were not producing harm," I said. "You were producing the opposite of harm." I decided the question could wait. She looked at me. She said, "That was the correct decision. Even though you did not know why it was correct. Tell me why." She took her hands off the shelving. She said, "Sit down." There was nowhere to sit in the supply room, so I sat on an overturned supply crate in the way of someone who is making do with what is available, which is, I have come to understand, the defining posture of everyone who has worked alongside Vera Strand for any length of time. She told me. She told me the way she did everything, directly, without performance, in the specific compressed language of someone who has delivered operational debriefs before, and who understands that the relevant information is the information that explains the outcome, and that the surrounding context is provided only insofar as it makes the outcome legible. She said, "My name is not Vera Strand. My name is the name Dunn told you. That name is classified, and I am going to ask you not to use it outside this room. What I am going to tell you is the part that is not classified, the part that explains what you have been observing." I nodded. She said, "I worked the overnight ICU at St. Clair for 4 years, a long time ago, before you were here. The archive has the record. When I left, I enrolled in a program that led to an operational medicine pipeline. I will not describe the pipeline. What I will tell you is that the pipeline produced a medical practitioner who is capable of managing critical care in environments where critical care infrastructure does not exist. Where the imaging is unavailable, the blood bank is a cooler in the back of a vehicle, and the specialist consultation is a satellite phone to someone 4 time zones away who cannot see the patient." She said, "I spent 3 years in that environment. I managed cases that no ICU physician in a building like this one has managed, because no ICU physician in a building like this one has been in a position that required managing them. I learned things, Not abstract things. Specific things with specific applications. The organism that Leon Hayes is carrying is one of the specific things I learned. I have managed 7 cases presenting with that organism. I know what it looks like, and I know what it responds to, because I have watched it respond and watched it not respond, and I have learned the difference. I said, the pipeline. The operational record. Dunn said you were listed as missing in action. She said, the listing was the correct administrative outcome for the circumstances. The circumstances resolved. The listing was corrected. When it was corrected, I had a decision to make about what came next. I waited. She said, I came back here because this is where I learned what I know. The 4 years I spent in this ICU before the operational work were the 4 years that made the operational work possible. The specific depth of ICU nursing that this floor required, the reading of the septic patient, the coagulopathy management, the hemodynamic interpretation. I learned it in these rooms with these patients. And when the operational work was over, I came back to the place where the work was real in the way that I needed it to be real. She looked at me. I did not lie to you, she said. The nursing license is real. The credential is real. The employment record that St. Clair has for Vera Strand is accurate in every clinical respect. The name is the only thing that is not the whole truth. The name was a necessity of the circumstances. It is not who I am. Who are you? I said. She said, I am the nurse who has been on this floor for 3 years, who has been right about the cases I have described my experience as informing, who has used what I know wherever it was applicable. That is who I am. The operational past is what produced who I am. The 2 things are the same person. I sat with this. I thought about the saline, about the badge, about the 3 years of small wrongnesses accumulating in my file, and the threshold I had set, and the threshold she had never crossed. I thought about Leon Hayes going in the right direction. I said, why did you come back to this specific floor? There are other ICUs in Cincinnati. She was quiet for a moment. She said, because the overnight ICU at St. Clair is where I became capable of doing what I went on to do. Everything I learned in the field was built on what I learned here. Coming back here was not hiding. It was returning to the foundation, she said. And because the patients on this floor deserve someone who has been in the worst rooms and who has not let the worst rooms change what they brought into them. That is what this work requires. I have that. I wanted to use it here. I looked at her. I said the badge, the saline, the things that should not be possible. She looked back. She said, the badge I can explain operationally. The saline, she stopped. A very small pause. The saline I cannot fully explain. I have been in situations where the standard physical laws of evidence were inconsistent. I have been in rooms where what should have been visible was not. I do not know the full explanation. I know that it has occurred. I know that it is connected to the operational circumstances in a way I cannot describe with the vocabulary I have. This was the most she ever said about the saline. It was not enough of an explanation. It was what she had. I accepted it. I brought him to the supply room. He came without asking where we were going. The specific trust of someone who has operated in environments where you trust the person in front of you to be taking you to the correct place. He came into the supply room, and he stopped. Vera was standing in the center of it, her hands at her sides, her face carrying the expression I had been trying to name for 3 years, and that I could name now. Readiness. Not for confrontation, for whatever the situation required. The specific, complete readiness of someone who has always known this conversation was coming, and who has long since made their peace with the fact that it was coming and who is, in its arrival, simply present for it. Dunn said, I spent 11 months in the gap between your last confirmed contact and the correction of the listing trying to understand where you were. She said, I know. I made 3 separate inquiries through 3 separate channels. I know. 2 of them reached me. I could not respond without compromising the circumstances. He was quiet. She said, the circumstances required the gap. The work required the gap. I am sorry for the 11 months. I am not sorry for the work. He looked at her for a long time. He said Hayes is going in the right direction. Yes. Because of what you knew about the organism. Because Dr. Whitman followed the recommendation, she said. The knowledge is mine. The decision to act on it was his. Dunn looked at me briefly, then back at her. He said, you have been here for 3 years, yes. In this ICU, working nights, yes. You could have gone anywhere. Any facility. Any specialty. The operational record alone, the operational record is classified, she said. It does not transfer to civilian employment. I came back to the place where I learned what I know, because the place where you learned what you know is the place where you can most fully use it. I have used what I know here. That is the correct outcome. Dunn was quiet for a moment. He said, there is going to be a process. A debrief. The administrative resolution of the gap. I cannot tell you the timeline or the outcome, but the process is going to happen. I know, she said. You can continue working here while it is underway? She looked at me. I said, she can continue working here. She looked back at Dunn. Then I will continue working here, she said. He nodded. He said Hayes is going to want to thank you when he is well enough. She said, he does not need to thank me. He needs to recover. Tell him to recover. Dunn looked at her for a long time. He said in the tone of a commanding officer acknowledging someone rather than directing them, you never stopped working. No, she said. Even after. The work was always the point. Not the context of it. Not the classification level. The work. The patients who needed what I know. Here or in a field, the work is the same. He held out his hand, she shook it. He left the supply room. I stayed. The break room gathered itself in the specific way that it always gathered after the hardest nights. Karen arrived first, because Karen arrived first on every hard night. She was the person who was always already in the break room when the rest of the team got there, already holding a cup of coffee, already positioned in the corner chair, ready to receive the gathering. The other overnight nurses arrived in the natural sequence of people wrapping up the post-case routine. Vera arrived last, which was also the natural sequence. Charge nurses complete the floor before they leave the floor. She sat down. Karen looked at her across the table. Karen said, tell me. Vera told it. She told it the way she had told it to me, compressed, direct, the relevant information in the relevant sequence. The operational pipeline, the years in the field, the specific circumstances that had produced the gap, the organism and why she recognized it. She did not tell them the name that Dunn had named. The classified name stayed classified. Karen listened without interrupting. When Vera finished, Karen was quiet for a while. Then she said, the badge, operationally necessary, Vera said. A condition of the circumstances under which the credential was established. I cannot be more specific than that. The saline. A pause. I cannot fully explain the saline. I know it has happened. I know it is connected to where I have been. I do not have the vocabulary for the complete explanation. Karen absorbed this. She said, Gerald Marsh. Vera looked at her. Karen said, you knew about the fire. You read it from the scar. The specific scar angle that told you it was a rescue. Yes, you learned to read scars in the field. You learn a great deal in the field that is not in the curriculum, Vera said. The scar reading is one of the simpler ones. There are more complex ones. Karen said, teach me the scar reading. A pause. Vera said, yes. Karen said, and the coagulopathy protocol you used on Vasquez. The fibrogen read, yes. And the chest X-ray interpretation sequence, yes. I will teach all of it. It will take time, but I will teach all of it. The break room was quiet. One of the other nurses, a woman named Jessica who had been on the overnight team for 2 years, and who was in the process of becoming very good at a job that she had chosen specifically because it was hard, said, the patients who came through because of what you knew, Okonkwo, Vasquez, the others. Vera said yes. You saved them with knowledge that nobody on this floor had. I saved them with knowledge that nobody on this floor had yet, Vera said. The distinction matters. Knowledge is not proprietary. It is transferable. The reason I am going to teach you what I know is that the next time a case requires it, it will not require me. Jessica looked at her. She said, that is a strange way to think about your own value. Vera said, it is the correct way to think about it. My value to this floor is not the knowledge I hold. It is the knowledge I can give. A practitioner who hoards what they know is a practitioner who has confused their knowledge with their identity. The knowledge is not mine. It was given to me by the situations that required me to have it. I am passing it on. The break room was very quiet, Karen said. I have 11 years on this floor. I have worked alongside 39 nurses in 11 years. You are the best of them. Vera said, thank you. Karen said, that is not a compliment. It is a statement of fact. You are the best, and the reason you are the best is that you have been somewhere the rest of us have not been, and you brought it back. I brought back what mattered, Vera said. Some of what I brought back I would rather not have. She said it quietly, without elaboration. The break room held the weight of it for a moment. Then Karen said, start with the scar reading, and Vera almost smiled. The specific smile that I had been watching for 3 years. The one that arrived without announcement and departed in the same way, that carried in it everything she was, and everything she had been through, and everything she had chosen to do with it after. She said, I will start with the scar reading. Leon Hayes spent 11 days in the ICU at St. Clair Medical. The first 3 days were the specific sustained critical care of a septic patient responding to correct management, the hour-by-hour monitoring, the antibiotic optimization as the culture results came back and confirmed what Vera had predicted, the source control holding as the drainage maintained its position, and the abscess cavity collapsed. The fever trended down, the lactate cleared, the hemodynamics stabilized and then improved, and then reached the territory of a patient who was not just not dying, but beginning to recover. Ray Dunn was present for all 11 days. Not in a visible way. He did not stand guard in the corridor or post his operators outside the room. He was simply in the building, available, monitoring from whatever distance the situation permitted. On the days when Hayes was critical, Dunn was on the 4th floor. On the days when Hayes was improving, Dunn was in the family lounge, reading, checking in with the team at the medication station at the start of each shift. He was present in the way that commanding officers are present for the recovery of operators. They consider their responsibility, without intruding, without demanding, without requiring anything from the medical team, except what the medical team was already giving. On day 8, Hayes was well enough to sit up. On day 9, he was well enough to talk. On day 10, he asked Dunn about the ICU nurse. Dunn came to find me afterward. He said, he wants to know who she is. I said, what did you tell him? He said, I told him she is the overnight charge nurse. I told him she identified the organism before the cultures came back. He said, how? I said, experience. He accepted this. But he asked me if she had a name. I said, her name here is Vera Strand. Dunn looked at me. He said, he is going to know that is not her real name, when he is well enough. He will figure it out. When he figures it out, she can decide what to tell him. Dunn was quiet for a moment. He said, you are not angry. About what? About the name. About 3 years of working alongside someone whose full identity you did not know. I thought about this honestly. I said, I am working through it. The honest answer is that I trusted her correctly. The trust was warranted. The thing I should be angry about is not that she withheld the information. It is that I never pushed for it. I had enough data to ask the question years ago. I chose not to ask because the question felt disruptive. That is a failure of professional curiosity that I own entirely. Dunn looked at me. He said, she would not have told you anyway. The circumstances prevented it, I know, I said. But I would have known that I asked. On day 11, Hayes was transferred to a military medical facility for the continuation of his recovery. Before he left, he asked to see the charge nurse. Vera went to his room. I did not go with her and I did not ask what was said in that room, because what was said in that room was not mine to hear. What I observed, from the monitoring station through the glass, in the specific peripheral awareness that 11 years of overnight ICU medicine produces, was a man who had been through something enormous looking at a woman who had also been through something enormous, and a conversation that had the quality of two people who recognize each other's experience, without requiring the experience to be described. It lasted about 12 minutes. When Vera came out, her face was the face she had after the hardest nights, not distressed, not shaken, but carrying something. The specific weight of a significant thing that has been fully received and integrated. She went to the monitoring station. She sat down. She picked up the next chart. She went to work. That was who she was. The administrative resolution of the gap took 6 weeks. I was involved in 2 sessions of it, both conducted in the conference room at the administrative level of St. Clair that federal inquiries always use when they come to this hospital. The people who conducted the sessions identified themselves in terms that were sufficient for me to understand the relevant institutional context, and no more. I was told what I needed to know. The employment record at St. Clair for Vera Strand was accurate in every clinical respect and would remain on file as such. The operational background that produced her clinical capabilities was classified and would not appear in the hospital record. The hospital record was the correct record for clinical purposes. Everything else was the correct record for other purposes. I signed the acknowledgement. I went back to my ICU. Vera's name on her badge remained Vera Strand. This was, as far as I could tell, both the correct administrative outcome and the most honest available option given the circumstances. Her name in this hospital, on this floor, in the work she did with these patients, was Vera Strand. The other name belonged to a context that this hospital was not part of and that the patients in this ICU had no need to know. The work here was the work here. It was real and it was hers, and the name under which she did it was the name that belonged to it. She kept working. She started teaching. The teaching happened in the break room between cases and in the moments the overnight ICU produces between its demands. The specific concentrated pauses of a floor that never fully stops, but that creates, in its intervals, the space for the transmission of knowledge from the person who has it to the people who will use it. The scar reading first, as she had promised Karen, then the fibrinogen-driven coagulopathy identification, then the chest X-ray interpretation sequence, the additional layers of reading that the standard teaching does not cover, because the standard teaching is built for standard conditions, and the additional layers come from the conditions where standard is inadequate. She taught the specific patterns of hemodynamic deterioration that she had learned in environments where the deterioration happened faster than the monitoring infrastructure could track, which meant you read it in the patient before you read it in the machine. She taught the organism knowledge, not in the classified sense, but in the applicable clinical sense, the way she had applied it with Hayes, the specific environmental and mechanistic clues that point toward organisms outside the standard empirical coverage. She taught the airway assessment under hostile conditions, which is not a phrase that appears in the standard curriculum, and which she translated, for the purposes of the ICU, as the airway assessment you perform when you do not have time to perform a standard airway assessment. She taught all of it. Karen said, in the break room one night 3 months after August 15th, I have been a nurse for 11 years. This is the most I have learned in any 3-month period of those 11 years. Vera said, the knowledge was sitting here unused. That is inefficient. Karen said, the knowledge was sitting in you. Same thing, Vera said. I want to address the saline. I said that Vera could not fully explain it, and that the explanation she offered was insufficient, and both of those things are true. But I also said that I accepted what she had, and I want to be honest about what that acceptance means for a physician who spent his training being taught that insufficient explanations are not acceptable explanations. I have been in medicine for 17 years. In 17 years I have encountered 3 things that I cannot explain using the clinical and scientific framework in which I was trained and in which I practice. 2 of them are cases, specific clinical outcomes, that exceeded what the clinical picture warranted, in ways that multiple reviewers, using the full documentation, have also found inexplicable. The saline is the third. I have the footage. The footage clearly shows a person in the bay. The footage clearly shows the floor beneath where the person should be standing. The floor in the footage is undisturbed. I have shown this footage to 3 colleagues whose clinical and observational judgment I trust. All 3 of them have offered the same explanations I offered myself in the weeks after I first saw it. Camera angle, lighting artifact, positioning, some specific combination of the person's foot placement and the camera's field of view that produced the apparent anomaly. None of these explanations hold up against the specific geometry of the footage and the specific residue pattern. I have filed it. I have stopped trying to explain it. Vera said, "It is connected to the operational circumstances in a way I cannot describe with the vocabulary I have." I do not know what this means in the framework of medicine or physics. I know that Vera Strand is not a supernatural being and that the floor of the ICU at St. Clair Medical is not subject to different physical laws from any other floor. I know these things. I also know what I saw. I have filed it in the specific category that every honest physician eventually develops, the category of things that are true and that the current framework cannot account for, and that the correct response to is documentation rather than denial. The documentation exists. I am the only person who has read it, for now. I still work the overnight ICU at St. Clair Medical Center in Cincinnati, Ohio. 7 years has become 9. The unit runs. The city feeds it what the city feeds it. We manage it. Vera still charges the overnight team. She is still the best nurse I have worked alongside in 9 years on this floor, or any floor before it. The teaching has changed the team in the specific way that great teaching changes teams, not by adding to what individuals know, but by raising the floor of what the collective knows, so that the capabilities that once required one specific person are now distributed across multiple people, and the cases that once required her specific knowledge are now within the capability of the team as a whole. This is what she wanted, not to be irreplaceable, to make the irreplaceable replaceable. I think about the 3 years before August 15th. I think about what I knew and did not pursue. The saline, the badge, the cold hands, the knowledge that went beyond what the curriculum produces. The specific quality of presence that the patients described and that the families wrote letters about. The Okonkwo family's Christmas card. I had all of it. I did not ask. I have made my private accounting on this, and the accounting says, I trusted correctly, and I trusted for the wrong reasons. The correct reasons to trust Vera Strand would have been to ask who she was, and to receive the answer, and to make the decision to trust her based on the full picture, rather than the incomplete one. I trusted her based on the incomplete picture, because the complete picture was not available to me, and because the incomplete picture was sufficient for the threshold I had set. The threshold was, is she producing harm? A better threshold would have been, do I know who she is? I am working on having a better threshold. She is helping me. There is one more thing. 4 months after August 15th, a letter arrived at the nursing station addressed to the overnight ICU team, not to an individual, to the team. The return address was a federal mailing routing that I recognized as the kind of routing that people with access to federal mailing systems use when they want something to reach a specific person without leaving a specific trail. I opened it. It was handwritten, short. The compressed, functional handwriting of someone whose training has always valued the minimum necessary words. It said, I am operational again. I wanted you to know. I was told that knowing might matter to certain people on your floor. Tell them it mattered to me, that they knew what I was carrying and used the right tool for it. The tool saved my life. The people who knew how to use it saved my life. The distinction between those two things is the distinction between equipment and the people who understand how to deploy it. I have never confused the two, it said. I will not describe the work I am going back to. I will say that I go back to it aware that there is a floor in Cincinnati where the people running the worst nights are better equipped than they were before August 15th. That awareness is not a small thing when you are going where I am going. It was signed P.O. Hayes. I read it. I gave it to Vera. She read it standing at the monitoring station. Her face did the thing that her face did after the hardest nights, carrying the weight of something significant, integrating it, holding it in the way that she held everything. Completely and without residue. She folded the letter. She put it in her scrub pocket. She picked up the next chart. She went to work. I watched her go. Behind her, through the glass of Bay 11, the overnight ICU ran its work, the monitors, the ventilators, the specific ambient sound of a floor that does not stop. Cincinnati outside the high windows was doing what Cincinnati does in the deep hours. Running quietly, the river moving in the dark beyond the city lights, the bridge lights reflecting in the water, the city at its lowest frequency, still working, still working. That is the whole of it. That is what it means to be the overnight ICU at St. Clair Medical Center. You keep working. You keep using what you know. You pass it on, and you trust the people beside you to do the same, even when, especially when, you do not know the full story of who they are. Because sometimes the story is larger than the clearance you have for it, and the correct response to that is not to stop trusting. It is to raise your threshold for what trusting means. She is teaching me that too. If you love this type of intense nurse-taking action tales, hit that like button. Share the video with your fellow thrill seekers, subscribe to our channel, and ring the bell so you never miss a new story.